Hey there, folks. So it's Thursday, and since I promised three streams a week for you guys, this is me on a second stream this week. I got smashed at BJJ practice yesterday. I'm feeling like crap. Still, I have to report a lot of MRI and CT scans. We are already at the 12 mark. I have reported a set of 12 MRIs so far, a few CT scans also, and we still have about 23 to go. Let's see. It's fine. Connection seems fine. Just going to share the screen. Screen has been shared. I have a brain scan here. Brain scan. Just fixing the position of my chat screen here. Yes, it's here. I don't know. Which scan is this? Oh, this is the scan. So let's go. This is a 72-year-old female. She says she has some memory loss. It's a brain MRI. They did the hippocampus coronal T2 sequence. And let's go for a sagittal T1. Where is the sagittal T1? This is it. Sagittal T1 and a axial T2. Why not? Right there. So axial T2. There is a lacunar infarction right there. There is some hyper intensity areas around the ventricles on the basal ganglia region. Quite normal. Let's see. Indeed, some lacunar infarctions, lacunar ischemic lesions right there. Maybe on the pons too. Yes, tiny lacunar ischemic old lesions, and there is a mild dilatation of the supratentorial ventricular system. Nothing major. Let's grab this is a T1, axial T1, which is not necessary by itself, but since it's here, let's just roll the images and look for any bright spots that could point us to acute bleeding. This is also very easy to see on the flare sequence. Where is the axial flare? Give me axial flare. Axial flare is here. It's a T2 sequence with an additional pulse that saturates normal fluid. So brain fluid is black, and anything that shines should be disease. So there is indeed some lacunar ischemic lesions and some microvascular disease, although this is a very noisy sequence. So much noise, probably related to a bad state of the coil. Coil must be an old, worn out coil, and it gets this much noise, which hides small lesions, as you guys might be thinking. it does. It doesn't help. It just makes things harder to diagnose. So let's go for a diffusion weighted sequence, see if there is any signs of a acute ischemic stroke. No signs of an acute ischemic stroke. Let's grab a SWI sequence, a susceptibility artifact weighted image sequence. This is shaky and noisy because we are dealing here with a poorly maintained scanner for sure. There are some tiny sites of blood product or calcification deposits or some other kinds of mineral deposits right there. See, there too. This is quite normal. Let's check for there is a inversion recovery sequence. Oh, freaking shaky, oriented towards the hippocampus and the amygdala. So there is a slight reduction in size of the hippocampus. It's unfortunately a very badly done sequence. It's too thick. They made it so as thick as any other sequence, so it's crap. See, we should have at least 2 or 3 consecutive slices showing us the dentate gyrus or gyrus, but we don't because it's a low resolution, too thick of a low resolution sequence with slices way too thick, way too not as thin as they are supposed to be. But as far as I can tell, there is a slight enlargement of the ventricular horns and of the choroid cistern and kind of a flattening of the dentate gyrus or gyrus, especially on the left. So this is MTA2, and the flare says to me it's in Fazekas 1 classification, tiny spots of bright gliosis. There is no contrast enhancement, so we have gone through everything we could possibly report on this exam. I'm just going to copy and paste my template because I have a template almost exactly like what I just described. Excuse me. And just going to switch for a MTA2. Oh god. MTA2 phrase right there for the hippocampus, which is nothing major. And I'm going to describe the small lacunar infections all over the encephalus. So it's done. Lacunar ischemic strokes. Just going to summarize our findings. So it's much easier for the referring physician to read and take action. So we are done here. And if you guys haven't already, consider hitting the like button and subscribing to the channel, share this video with people you know enjoys diagnostic radiology. As I said in the beginning of the stream, I'm going to stream 3 times a week, just like this, sharing the screen, downloading MRI and CT scans, and reading with you guys on the fly, answering questions and anything that pops out in chat, and of course speaking about my findings, why I do this, what I think the diagnosis is, how to describe the lesions, what to be careful about, and all this good stuff that I suppose people online would enjoy watching. So if you'd be so kind as to hit the like button and subscribe, I'll really appreciate it. I'm streaming at this time because this is the only time I have available. Later in the evening, I'm usually really tired. I can't really speak much, and it gets really difficult for me to express myself, especially because I'm not a native speaker, as you guys have noticed, and speaking English makes me struggle even more than just reporting exams. So it's a fair struggle, and I have to have energy left to do both for at least 1 hour, 1 hour and a half, so we can enjoy ourselves and these fabulous exams. So this seems to be, for me at least, a quite normal exam. This is a 62-year-old female patient, and it says brain evaluation. So we are supposed to evaluate her brain. And she is diabetic and has chronic high blood pressure, and she also takes some sort of antidepressant medication. And of course it says she has gone through dental surgery, and she has no other complaints. So I don't know what we are doing here. It seems to me this is a normal scan, and we can actually see some minor bright spots on flare all over the brain white matter, which is almost a Fazekas 1 classification, just tiny spots of gliosis. And I can't say this brain is reduced in size because this patient is 62 already, and it seems quite normal to me. See, look at this bones, this brainstem. It's really, quadrigeminal plate is just fine. Check this corpus callosum. It's just quite normal. Cingulate gyrus also quite normal. So I'm just going to get a template that I have that's almost a normal template, but it adds up a few tiny spots of white matter gliosis and the Fazekas 1 classification on the summary. And this is it. Let me just check for a last thing here. Yes, this is it. I can't say much more than just that. So let's see if we find here a more intriguing and interesting exam. This is a 33-year-old female. She has gone through a contrast enhanced brain scan, and it says she is going through it doesn't say anything really. It just says she has to go through the exam, and there is no clinical history whatsoever. Newsflash, this is just our everyday routine. It could be worse. It could be a lie. It could be a fantasy written on the exam order, and we could be looking for some disease that doesn't even exist. So it's better to be empty than to be filled up with gunk, with useless information. So I'm starting off with the flare sequence. This is a XL flare sequence. It's shaky, it's kinda noisy. This is an old machine, poorly calibrated, and the patient is clearly not holding still. Still, we can't tell anything more than this is looking normal. This is a T2 weighted sequence with an additional inversion recovery pulse that saturates signal intensity from normal fluid. So next up, it's a gradient echo sequence, a gradient echo T2 star sequence that shows us calcium and mineral deposits, also signs of old bleeding, and it's really normal. It is a T1 axial, which isn't necessary, but this should be an old protocol of over 20 years before we adopted sagittal T1 sequences as a standard sequence for brain MRI. This is a diffusion weighted sequence to look for acute stroke. Nothing here, it's just plain fine. T2, the actual T2 sequence, not the flare, not the T2 gradient echo sequence, just a regular T2. Can't really see much here. The eyes and the orbits are fine. There is some slight sinusitis on the left. Not going to report it because this isn't a exam for that, for sinusitis. Oh, we have a sagittal T1 and it's normal. The pituitary gland also looks normal. Corpus callosum, fine and dandy. The dural sinuses, sinuses, I don't know how to pronounce that, but the thingy right there looks fine to me. Let's just roll the flare. Yes. Is there contrast enhancement in this case? No, no contrast enhancement. There is a coronal sequence that they try to make it for close-up analysis of the hippocampus, but it's not properly done. It's low resolution, but seems fine. And ADC map that makes no sense to analyze because the diffusion weighted sequence is normal. So this is fortunately yet another normal exam. Okie dokie. Let's grab another exam. We have a bunch of brain scans. I tend to group my scans by site. or specialty, so I can focus on a limited quantity of possible disease presentations, so it's easier to figure out stuff. If you go back and forth between specialties, it makes it tougher to wrap your head around it, at least for me. So I tend to report a bunch of brain scans, then spinal scans, vertebral scans, then I go to knees and shoulders and all that, and then small bones and joints, and then I go back to brains, and I hit some specialties on head and neck, so it makes a change and makes reporting less boring, and I go back and forth. We still have 3 brain scans to go. Oh, this is something else. This makes sense. This is a contrast enhanced brain scan. Patient, it's a male patient. He is 57 years of age, and it says here he has headaches and has gone through some sort of trauma to the head in the past. So this yeah. So this is flare. This is T1. So flare right there. There is a major surgical site right there. There is bone remodeling. There is a partial craniectomy right there, and a huge area of Malacia and gliosis on the left frontal lobe, and a severe or at least moderate dilatation of the frontal horn of the left lateral ventricle. So this is indeed a chronic lesion. I can see the ependymal surface right there. So there should not be a direct communication between the area of Malacia and the ventricle itself, but it could be. I can't really be sure if I don't have a very thin and volumetric acquisition, which I don't have here. They didn't do anything like that because why help us report this crap if you can make our life just a tad bit harder? So if you can make if the technician can make the radiologist work harder, he will definitely do it just out of laziness. Why do it right if you can be lazy and do it just wrong? That's how life is. I can't see much more than that on these particular sequences. We should have hypo intensity areas around the site of Malacia, because this once was at least partially flooded with blood. So there should be blood deposits around the site of, just like that, of Malacia and gliosis. Fine. Diffusion weighted sequence. Is there anything that draws our attention to a possible site of acute disease? No acute disease, just chronic disease. T2 is here. Yes, major area of a brain excavation, a huge site of loss of brain matter, just like that, and a moderate dilatation of the anterior horn of the left lateral ventricle. Let's see how that looks. See, that's how it looks on the sagittal view, and of course it's dark in T1 and bright in T2 weighted sequence because it's pathological. Yep, the pituitary gland is fine, all the cisterns is fine, and besides that particular site of disease, the rest of the brain and associated anatomy seems quite fine. The orbits are okie dokie. Some sinusitis, but there is always sinusitis. There is really no need to describe that. Oh, we have a contrast enhanced sequence right there. So beware of possible thrombosis. I had a case yesterday of headaches, and they thought it could be an aneurysm, so they ordered a arterial intracranial angiogram and also a neck arterial angiogram, and I could see that the patient had an acute thrombosis of the superior sagittal sinus, so a very dangerous thrombosis. There is no detectable enhancement on the margins of the site of lost brain matter, which means this is a very old site of disease, not a nearly established one, because that could be a slight enhancement on the margins of the Malacia and gliosis region. So this is old news. Let me just check for anything on the flare sequence once again, so we can move on with our lives. Oh, some tiny bright spots. I'm just not going to report that because this is a trauma patient in that area of Malacia and gliosis, and blood product deposits is just freaking huge. So let's report it. This is a very common lesion. Trauma to the head in this kind of lesion is quite common, so nothing major here. It is just a major area of Malacia, gliosis, and blood product deposit, which is, I suppose in English, called hemosiderin, because in Portuguese it's hemosiderin. And there is a moderate dilatation of the corresponding lateral ventricle. Yes, let's just summarize that. No contrast enhancement. And we are done. Yet another brain scan bites the dust. Yep, go, sign it off. We still have 2 brain scans to go. How's the streaming? We are 32 minutes in. We've gone through a bunch of brain scans. I'm already downloading the next one. It's a 53-year-old male. This is an enhanced brain scan, and he has some clinical history, I guess. It says he has temporal lobe epilepsy. He has had acute seizures for the last 15 years. So he uses a bunch of stuff, and he had a CT scan that came out normal. So we are looking for temporal lobe sclerosis, most probably, or some sort of presentation lesion that could justify a secondary epileptic syndrome. The right lateral temporal horn of the lateral ventricle seems asymmetric, and the head of the hippocampus seems odd to me, maybe a bit sclerotic, maybe a bit bright on T2. There are tiny foci of gliosis on the white matter, deep white matter of the frontal lobes. T1 seems fine. This is flared. This is T1. So T1 seems fine. This is a quite normal brain. Let's go for a T2 star gradient echo sequence to look for abnormal mineral deposits, calcifications, and old bleeding sites. Nothing major. Diffusion weighted sequence. Let's roll up and down, see if there is any signs of restricted diffusion compared to the normal brain parenchyma. No, nothing like that. This is a T2 sequence. Indeed, there is some asymmetry of the anterior portion of the right mesial temporal region. Let's go for the coronal. Oh man, this is such a bad coronal, but still I can see there is a the hippocampus. It's shaky, it's malpositioned, and it's low resolution, of course, because why not, right? Why make my life easier if you can just make it crappy and harder? So why not make the radiologist struggle? They could have done just this sequence good enough so I can readily do the diagnosis and move on with my life. But no, they have to make the single most important sequence the worst of them all. Of course, why not, right? Why not? It's just so there is an abnormal morphology of the body and the head of the hippocampus. It's a tiny bit brighter than it's supposed to be, irregular and reduced in size. So this is a classic appearance of a hippocampus sclerosis. Oh, they made another sequence and it's even worse. And they tried to do a axial sequence that makes no sense and it's also crap. And then they did a volumetric T1 sequence, post contrast enhanced sequence, which helps no one. It helps no one, and there is no freaking need for contrast enhancement in this case. But as you guys can see, this temporal lobe is screwed over. It's all distorted and sick. So this is the cause of the temporal lobe epilepsy. And of course, the CT scan report, it was wrong. I'm sorry, but it is what it is. They should have seen this on the CT scan, but they didn't because they didn't look for it. This is in a tiny mesial temporal sclerosis case. This is a very clear and easy to see even on a CT scan. There is no excuse for that. Hippocampus on the left is fine. I'm just going to report the right hippocampus as sclerotic. There we go. There we go. Oh. So differentials. Nah. Let me just see if I can spot any. I can't really. Just. It's just way too much, mate. Just. It's okay. That's quite enough because this sequence sucks. Yeah. Let's just move on. Enough is enough. Let's go to the next one. The next one is also a brain scan. And downloading. This is a male patient. He is 44 years of age. And brain MRI scan, and the motive, the reason, it's epilepsy. Some kind of epilepsy. And once again, the CT scan came out normal. Let's see if we can tell if this patient has primary or secondary epilepsy. There is a bright spot right there on the apex of the petrous bone on the left. This is usually just fat or a bit of fluid. It's not usually a matter of concern, and it really shines and draws attention if you know what we are looking for. Not going to care much about it because we are looking for a motive for epilepsy, not dizziness or facial nerve palsy or paralysis. So T2 star, gradient echo sequence is fine. The flare is also fine. There is a tiny asymmetry between the temporal horns, although I can't really tell on this sequence any asymmetries on the mesial temporal regions, at least not until we look for it on the T2 sequences. It seems fine to me. T1 is great. Diffusion weighted sequence, no signs of excessive restricted diffusion. No. T2, first T2, fine. Seems fine to me. What do you guys think? I think it's fine. It's big. It's symmetric. It seems okay. Oh, the apex of the petrous pyramid or pyramid seems fine. This is sagittal T1. Sagittal T1. This is artifacts, acquisition artifacts. This isn't blood. Just acquisition artifacts like that. See how it goes on from the back to the front, right there. This isn't a bright spot of acute bleeding. This is just a artifact of image acquisition because this is a very old and badly calibrated scanner. Just crappy image capabilities. Let's see. Sagittal T2, which makes no sense. Not supposed to make a sagittal T2. They make a bunch of useless sequences, and they should improve the few sequences that make sense to be done, so they would still save time and make a much better exam, but they make a bunch of useless sequences, and all the sequences on this exam are low resolution with way too thick slices and filled up with noise because they scan too fast, and the patient gets tired and starts moving, and the starting sequences always look a bit better than the last sequences, because the more the exam lasts, the less the patient will cooperate. So it's just useless to be like this. So there is a slight asymmetry between the hippocampus, but still they are morphologically fine. It's a bit crooked. it's a bit crooked. So is the para-hippocampal gyrus, so, and the brain amygdala. So it seems fine. Let's see if there are any signs of heterotopic brain cortex or gray matter. Any signs of nodularities around the ventricles. Any deformity of the lateral cisterns. Any kind of diffuse disorganization, diffuse architectural distortion anywhere on the brain. It doesn't seem so to me. It seems fine. See, hippocampals are fine. That is a volumetric T1 post-contrasting enhanced sequence. Just do an MPR. Grab a axial because real men only need axial sequences. Sagittal and coronal are for children. And see, this once again, this is that stupid artifact right there and right there. This is all a very bad old worn out coil that they insist on using to save money and make horrible scans. It's as shaky as it gets, but cortical matter, the gray matter is gray here on this sequence, and the white matter is slightly less gray, almost white, so we can easily look for heterotopic sites of gray white matter that could be a cause of epilepsy, congenital or early acquired epilepsy. Seems quite symmetrical and quite fine. There is a small, very tiny lacunar scar right here on the body of the caudate nucleus on the left. Let's see if I can find this on that crappy flare. Is that so? Oh, see, the flare is so thick I can't see the site of lacunar infarction. The patient just got himself a normal brain exam because of the exam's resolution being so freaking bad. So this is a normal exam. It could be different, it could not, it could be a pathological exam, but it's just that bad. So nothing to report, just good old normal scan. So this is it for our brain scans. We are already 51 minutes in on this live stream. Live stream seems fine. It says it's healthy. And let's go for a temporal mandibular joint scan. It's not every day we get those, and they are quite easy to report. It's quick, it's easy, and it's usually normal. So I have a template, of course. I like to separate right from left and report them one by one. I just report the right temporomandibular joint, and then I go to the left temporomandibular joint, so it's easier to report and easier to read, although the report itself gets kinda larger. So this is a T2 useless sequence that I just can't properly image the joints, but still they've done it. This is a coronal PD, I guess, or T1. It is coronal T1. That is the disc right there, and I can already see there is some kind of degenerative disease on the left right there. This surely isn't a normal scan. Parotid glands are there. This is probably, yeah, these are probably lymph nodes, just like that. But we are not reporting a neck MRI. This is a temporal mandibular joint MRI. So I keep this sequence here, this or that coronal sequence, so I can properly see which side I'm looking at. There is flattening and sclerosis and irregularities of the mandibular mandibular head on the left. So this is arthrosis. The same I can say about the mandibular fossa, and there is clearly a effusion right here that we are going to see much easier right there. Tiny effusion, and the disc is here. It's dislocated anteriorly. This is also fluid. It's folded and distorted, and it's also kinda odd looking in terms of signal intensity. So this is a arthrotic arthrosis with signs of acute disease and anterior dislocation and degenerative disease of the disc as well. It's going to be much clearer to you guys as soon as I show you the other side. The other side is normal. See, this is disease, this is normal, and the disc is right here. The disc is here. Let's go for the T2. See, the disc is here, and here is the normal disc, well positioned, and the normal head of the mandible and of the normal surface of the temporal cavity right there on the right. So we have a normal right temporal mandibular joint and a arthrotic bad looking left temporal joint, temporal mandibular joint. This is an incomplete exam because they didn't do a fat saturated sequence, nor they did a proton density sequence. I don't know why they do this. They did a coronal T1 that makes no sense. They did a axial T2 with that coronal T1, which also makes no sense. Oi, meu filho. São 10 para 2.
Aquele lá que tava. Ele esteja desconfigurado.
Tá bom. And they didn't do the necessary PD sequences, which are the best for cartilage and the correct evaluation of the disc. See, this is an open mouth sequence. The disc is properly placed and normal. on the right, and there is a restricted motion of the left joint, and the disc indeed is all screwed up right there. This is a bad looking joint for sure. So right is fine. Let's go for left. Small effusion. On the superior compartment of the joint. The temporal eminence is fine. Anterior dislocation and degeneration of the disc. And the movement of the joint is greatly decreased or reduced. So this is a classic case of temporal mandibular joint dysfunction as imaged and diagnosed by an MRI. Not a properly done MRI, but nonetheless it's feasible. And so we are done here. This was nice for a change. And let's grab a cervical spine. A cervical spine scan. What do you guys think? Cervical spine. Seems nice to me. Cervical spine. Yes, cervical spine. So we can hit the 20 scans reported mark today. Only 50 to go. It seems this is a 33-year-old female, and she says nothing. There is no clinical history whatsoever, because why would there be? Why help if you can make my life complicated? If you can make my life worse, why would you bother making it easier? It seems to me there is some kind of diffuse signal intensity disturbance right there. Do you guys see? But I have no clinical history, and this exam is all shaky, and it has way too much noise. See, this is an STIR in fat saturation T2, and those spots of bright signal seem to be worse indeed. So let's just see. It goes from C1 all the way to C2, C3, and C4. It's about 5.4 in the longer axis. I'm going to report that. Still, let's see if the... Oh, they didn't do a axial T2? Really? No, no way. No way they didn't do an axial T2. I don't believe it. They must have done it. No, they didn't. So this is an incomplete exam. Let's just send it back. Not going to waste my time on this because I can't properly report it. Let's just send it back and let's grab another. A dorsal. A dorsal. Spine, MRI, dorsal spine MRI. Just stupid. Stupid can that be? Just freaking useless. Freaking useless exam. Oh, this is contrast enhanced. It's a young female, and yet again there is no clinical history whatsoever. There is some degenerative disease of this disc right here. This is a T2 sagittal. A terrible sequence. Just noise and movement artifacts. Yet, let's see if we can do anything about this. Yes, just this disc seems abnormal. And let's follow this. This is just make believe. This isn't really a proper exam for the medulla. Just see if I can see any gross disease. Couldn't possibly see tiny small disease in this because it's just terrible. It looks like a localizer. And check this crap out. See, this is what I'm telling you guys. This is just horrible. It's just make believe. It's really not a proper scan. This is a post contrast XL21 with a huge field of view, very low resolution, and very thick, very thick slices. It goes way too up and way too down, and it doesn't scan anything properly. It just makes it's supposed to do it makes the patient believe he was scanned, but he wasn't properly scanned. There is no way any diagnosis could come out of such a terrible, horrible scan. So we're just going to report it and go on with our lives because just can't dwell on this kind of crap. Just going to put a small disclaimer here. Yes, this is it. Yet another great final MRI. So we are already past the mark of 1 hour of streaming. I thank you so much, guys, for being around. Nobody showed up in chat, but I hope someone watches this and leave comments below. Please hit that like button, consider subscribing to the channel, and stick around for the next stream, probably on Saturday or tomorrow. I really don't know yet, but I'll be sure to send out a reminder. So subscribe to the channel and turn that notification bell on so you guys can see when I schedule the next stream. And if you are interested, you can join our Discord server. The link is on the description below. I also post there whenever I'm streaming or posting videos. So, and if you want to chat and to talk to me, that is the best channel to do so. So we are going to see each other on the next stream. So long. Thank you. Good afternoon. Yeah.